Hey, welcome everyone to Sounding Board. Our speaker today is Professor Chip Schooley. He's Distinguished Professor of Medicine in the Division of Infectious Diseases and Global Public Health. He's also the co-director of the Center for Innovative Phage Applications and Therapeutics at UC San Diego. He has a long and distinguished career in battling multiple infectious disease epidemics, including HIV and COVID-19. And it's very appropriate. Today is a World AIDS Day. So this is a very particularly relevant talk today. And I'm very honored to introduce Dr. Schooley, whose title today of his talk is Pandemics, Paralysis and Pragmatism, What We've Learned in the Era of AIDS and COVID. Dr. Schooley.
Thanks very much, and good afternoon, everybody. It's a pleasure to be here with you, and I would encourage you to just jot your questions down as we go and try to get to all of them at the end. We've been kind of at the COVID scene for about the last 3 years, and I think it's appropriate now on World AIDS Day to reflect on kind of where we are. I think I'm sharing the wrong screen. Let me go back and see if we can get the right screen up here. All right, are you seeing the presentation screen or not at this point?
Yes, I can see the presentation screen.
Great.
Learning from COVID. Are we better?
Perfect. All right, great. It was what was showing here was ambiguous.
Ah, okay.
So let me just get us going here, and we can all right. Are you seeing the presenter's view or the full screen view?
I think we're seeing the presenter's view.
All right, there we go.
That's the full screen. Yes, thank you.
Okay. So I thought I would do today is to try to spend a little bit of time at the beginning talking about some of the things we learned from our response to the COVID outbreak. And many of these are some of the same lessons we should have learned from the HIV outbreak that came our way now almost a little over 40 years ago. And then speak a little bit about where we are in the COVID pandemic as we head into our third winter with new variants coming our way. It seems strange that it really was just 3 years ago this month. Sometimes it seems like a lifetime when we began to hear about a strange respiratory illness that was beginning to circulate in central China in an area around Wuhan, a city in China that is known for its manufacturing and is, like many Chinese cities, extremely dense. The initial cases were found around a wet market where chickens and other animals were being sold, and was spreading through the population beginning about the middle of December. No announcements were made, but it began to be noticed that there was something going on, and people began to talk about it on WeChat. One of the people who talked about it is this man who, in my view, is one of the heroes of the COVID pandemic, Dr. Li Wing-Lang, who was an ophthalmologist, and he saw a patient in December of 2019, and then noted that the family of this patient became sick soon thereafter, as did he, and he began to worry about there being a contagious respiratory virus circulating in the community. Chinese authorities were aware of this and were not anxious to have this rumor spread, and the authorities came to him in the form of the police and told him that he was spreading rumors and would be disciplined if he continued to chat about it. He was silenced, and to make a long story short, his voice was drowned out and he died of COVID 2 weeks later. It was only after his death that people realized that he was the one trying to sound the first warnings that this was spreading. Had people paid attention to it at that time, there was a much better chance this could have been contained around the area of the first outbreak. Lesson number 2 is the world's a small place. We in the US began to see this pandemic At the time, it was just an outbreak spreading in China. And many people in the US kind of ignored this and thought, well, this is pretty far away. We're not going to have to worry about this in the US, forgetting about the fact that we're a very interconnected world these days. Oceanids has been one of the drivers of this and has made our world a much better place by helping tie us together and bring all of the strengths of all of our cultures to each other. But the flip side of this is that pathogens can spread very quickly around the world in ways that allow them to basically hop from continent to continent in 12-hour periods. Initially, the first cases were, as I said, around Wuhan, but they then began to spread throughout China. And this is from a presentation made by Jinya Wu, who was one of the original chroniclers of the pandemic in China from the China CDC, at a presentation that I chaired in March of 2020. Until China had gotten to, until things had gotten to about the middle of January, there was a lot of thought that the pandemic would never get beyond China. But as you can see here, by the time Dr. Wu was giving his talk, the virus had already spread around the world and was spreading rapidly, particularly in Europe and the United States. Lesson 3 is that whenever there is a new infectious disease outbreak, we tend to pay attention to the most severe cases first. They're the ones that come to medical attention first. And people who have milder illness or who are asymptomatic don't come to our attention. And that has a couple of important implications. First of all, it may cause us to overestimate the severity of an individual case. And secondly, it causes us to underestimate the prevalence of the virus. For example, the official number of cases counted in the United States by March 17th of 2020 was about 6,000 cases. In fact, the actual number of cases was closer to 8 times that because the only cases we were counting were people who had been symptomatic and had been tested. When in fact, using mathematical modeling, it was clear the virus was much more widespread than had been thought by the data that had been put out previously. Now, this was important because it made it much less feasible to put up guardrails based on limiting immigration and by assuming that if you hadn't been in contact with someone who had been in a place where the virus had been found, you were not at risk for COVID. We made the same mistake when the so-called Mexican flu was initially found here in San Diego back in 2009. At that time, the CDC defined that illness as something that could only be found in someone who had been recently been to Mexico or been in contact with someone from Mexico. And it led to a major underdiagnosis as the virus spread around the country. The same thing happened with COVID. A good example of that was what happened at UC Davis. This was the first reported case in the United States of someone who came to medical attention without having a known contact with someone from China or having been in China herself. This is a woman who lived near Sacramento and presented to her doctor with a upper respiratory illness and a chest x-ray that looked very much to the physician caring for her like COVID. She was admitted to a local hospital up there, and they got in touch with the CDC, which at the time was controlling all of the COVID tests in the country. You couldn't get a COVID test unless they approved the test. And when they told her that, they told the CDC that she had not been in China and hadn't had any contact with someone from China, they said, well, there's no reason to test her, and they refused to allow her to be tested. She got progressively worse and then was transferred to UC Davis, where they initially refused to test her again. And finally, after insisting that she be tested, she was tested and turned out to have COVID. Now, several days after having been in 2 different hospitals with people dismissing the fact that this could be COVID because she didn't fit the case definition. So when all you do is look under a lamppost, all you see is what's under the lamppost. So we have to be very careful in our early definitions of cases, not to be distracted by what the first case looked like. Now, one of the reasons that we were having trouble with making diagnoses was a major problem that the CDC and the FDA caused related to COVID tests. The way laboratory tests are rolled out in the United States is that they have to be validated and then have to be taken through a process that involves approval by the Food and Drug Administration and validation with a certain number of tests with the patients with the disease, without the disease. And the FDA can decide or not whether or not to approve a test that is developed in somebody's homegrown laboratory. And a decision was made early on that it would be very hard to get these tests approved anywhere except at the CDC. The CDC would make all the tests, they would ship the tests out as needed, and people would be dependent on their tests. The CDC liked this because A, there would be a single test used around the country and it would be theirs, they would understand its operating characteristics, and B, they would control all the information about where the pandemic was. The problem was they were not able to make the test in a timely fashion. They had all kinds of production problems, and we were left at a time when the WHO had already shipped out 250,000 tests, with the CDC only able to ship out a couple hundred tests, and people who had patients like the one I spoke about were not able to test them because of a limitation in the number of tests. Now, when this fiasco became apparent several weeks later, we had people, as you may remember, driving around parking lots trying to get tests that might not come back for weeks. A decision was made to relax the tests and let academic laboratories get emergency use authorizations to quickly make tests available more broadly around the country. And that was one of the turning points in our ability to understand the true magnitude of the pandemic and to be able to begin to use information about where the cases were to help slow the spread to other patients. Another mistake we made with AIDS, and one that we quickly replicated with COVID, was to let the politicians get involved in making scientific decisions. You may remember in the AIDS days, the president didn't mention the word AIDS, never came out of his mouth until his friend Rock Hudson became infected. And then several years into the epidemic, he was able to mention this. And it was several years later before a real scientific effort to stand up a response to this was launched by the NIH. In the case of COVID, it was known early on within the U.S. government that this was going to be a major problem. By the end of January, people in the cabinet were pretty certain that this may well become something that would imperil the world and cause a problem with commerce and health. But this was downplayed because there were concerns that it might dampen the economy, which would have an impact on the re-election campaign, which was just beginning to get started. The impact of this was, of course, that it was very hard to make public health decisions that required people to do things that were unpopular, like wear masks, or to take seriously a virus that was spreading rapidly at a time when we could have slowed its spread dramatically and had fewer people infected before a vaccine became available. Another lesson that is important is that investing in science is critical. And that was very clear from the rapid outpouring of work that led to a very highly successful coronavirus vaccine, as well as effective drugs, remdesivir, for example. These scientific achievements, however, were not matched by the transmission to the public about the validity of these scientific findings. And that led to people not being willing to be vaccinated, large segments of the population, part of it being overlaid by the political overtones that I mentioned a minute ago, and also led to a lot of bogus cures, hydroxychloroquine and ivermectin, totally ineffective in dealing with COVID, but led by a number of fringe physicians and right-wingers as examples of drugs that were working, but that were being suppressed by the government and the pharmaceutical industry at the expense of people's health. And then the final lesson I think that we should pay attention to is that we haven't done a very good job of explaining to the public what science actually is. And the reason I think this is important is we're about to see hearings in Washington starting in January about the US response to the COVID pandemic. And one of the people that I think had the biggest impact on moving us in the right direction was one of my former mentors, Tony Fauci. The plan is to bring him before Congress and say that he lied to the public because things he said early on turned out not to be true. And what people aren't understanding here is that Tony is a scientist, and science is a field in which we use observation to expand what we know about things. In other words, science is a moving field, is a moving discipline in which we add knowledge by observing our world and by conducting experiments. Science doesn't stand still. And a fact is something that we know has happened and is something for which proof exists and about which there's information that's widely available and clearly no longer an hypothesis. Now, one of the mistakes we made is when we talked to the public in an effort to simplify things, we stated things in ways that were overly reassuring. For example, when the vaccine first became available, people were told, if you just get vaccinated, you'll never get COVID again. Nobody knew that at the time. In fact, there was very good reason to believe, based on what we knew already about coronavirus immunity, that immunity would wane and people would need to have booster shots. But a decision was made to simplify the message so the public wouldn't be confused and to try to use that to encourage people to get vaccinated. The price we're paying now is that later as things rolled out, people are saying, well, you knew at the time that this was not the case. Why did you lie to us? Early on, people were discouraged from wearing masks in public. This was partly driven by the fact that we didn't have enough masks to even cover most hospital settings. Rather than saying we think masks, we don't know yet about whether masks should be used, but we need to use the stocks we have in hospital settings. People were told they didn't need masks, and then later they were told they did. And this kind of seeming contrast in what was told at different points in time has been put forward as scientists lying to each other, lying to the public, when in fact what it really was a failure to communicate clearly. Now let's see where we are and where we might be going over the course of the coming months. This is a pandemic curve that kind of shows you the waves of COVID we've gone through, starting from our 3 years ago, going through our initial year of large numbers of people in the hospital, large numbers of deaths, things quieting down by the summer of 2021, then Delta coming along last fall, and then Omicron coming along last December. And now in the spring, Omicron variant BA.5, and more recently now things are heating up again with two new variants, BQ1 and BQ1.1. This series of waves of infection reflects, as I'll show you in a minute, the evolution of the virus, and is something that we see with multiple other respiratory illnesses, particularly as seasons wane and people come more into contact with each other at points in the year that we come inside. The California pandemic curve is almost identical. You can see the same waves I showed you a minute before, as well as the uptick over the last month in cases in California after a nadir about Thanksgiving. We're beginning to see in San Diego County an increase in the number of cases of people with COVID in the hospital. We now have about 300 in the hospital. We were running about 100 last July. And you can see now that we're clearly on the upswing as a new wave of infections begins to get here. Now, one of the ways that we follow where we are and where we're going is to look at the Point Loma wastewater. This is something that Rob Knight's group has been leading along with Christian Anderson at Scripps, and something that UC San Diego, led by its chancellor, has invested in a big way. to help us understand both at the university and the community where our pandemic is going. The reason this has really been very helpful is that this coronavirus infects not just the lungs, but also the GI tract, and we shed viral RNA, viral nucleic acid, in our stool, and we can measure that RNA in wastewater at Point Loma, which is essentially a way of taking the pulse of the entire city by just testing on a given day by just testing a single sample of water. You can see in blue, in this very much wave-like way that I've been seeing you, waves of increases in COVID RNA in the wastewater that have been coinciding with the number of cases reported in the community. And what you can also see is that there was often a shoulder of an increasing number of cases predicted by the wastewater that was then followed a week or so later by new cases in the community. We bottomed out with SARS RNA in the wastewater at Point Loma on Halloween, with about 750,000 copies per liter of water. We're now up to about 5 times that at 4 million copies. And that's been a steady increase. So the indications are that we're heading into an increasing number of cases over the course of the next 6 to 8 weeks. Now, why are we seeing this? We're seeing this because of viral evolution. Now, this is a cartoon of the virus showing you up here the kind of the body of the virus that's festooned with these spikes. These spikes are the way the virus attaches to our cells through a specific receptor on the surface of lung cells and GI tract cells. This is the structure that we make antibodies to, our immune response, when the virus infects us or when we are vaccinated. But what the virus has been doing is allowing this spike to evolve through random mutations with new viral variants emerging that are less susceptible to the immunity in the population. And if you look at what's happened over the last year or so, this is kind of a dendritic tree of the genetics of COVID, starting with the initial Washington strain, show it right here. The distance from this Washington strain is a way of expressing how different a given strain is. So what you can see is that the beta strain is different from the Washington strain by about this much. The Delta strain is different about this much, and they're different from each other. And if you look at what's happened in the first 2 years, this got us to last December. What's happened since that time is the acceleration of evolution an acceleration of evolution has been occurring with the Omicron strains, with new variants occurring every several months. And now what we're seeing is new strains, BQ1 and BQ1.1, that are different from the ones that we had in the summer, and BA5, which is part of the new COVID vaccine. When you look at what's going on in Point Loma, we can also use the water in Point Loma to look at the variance in the water. This is the time axis showing that, for example, back here in last fall, we had really mainly Delta, this red one. And then we then begin to see Omicron variants showing up in waves, with finally BA5 being what drove things in the summer. We're now seeing BQ 1.1 occurring, to the point now that the major variants in Point Loma are beginning to be these BQ variants rather than the older variants, BA4 and 5. Now, what that will mean is that the immunity that we developed as a population from being infected earlier, or from being vaccinated with vaccines that look like these, the earlier variants, will be less protective against the new variants going forward. There is still significant cross-protection from disease, as I'll show you in a minute, but less cross-protection from new infection. And to try to put that in a graphic way, let me show you one last data slide. This is work that has taken volunteers who've had three vaccinations with the original coronavirus vaccines, one of the Moderna shots or the Pfizer shots. These are people who had 2 boosters. These are people who had 3 of the original vaccinations plus a bivalent booster. And these two groups of people over here are people who had, in addition to being vaccinated, also had been infected with an earlier and a more recent Omicron variant. Now, if you look down here along this axis, these are individual viruses that are made to look like the original Washington variant, one of the early Omicron variants, the more recent Omicron variants, and variants that are coming. And this is the level of neutralizing antibodies that you have to each of these variants based on where you are with whether you've been vaccinated and boosted. And what you can see, if you just look, for example, at immunity to the original strain, if you've had 3 shots, you have an immunity level of just below 10 to the 4th units. If you've had 3 shots and have also been boosted, your level of immunity is higher than that. You can see that if you've only had 3 shots, though, as you get out to these more recent variants, your level of immunity gets lower and lower to the point that in terms of neutralizing antibodies, you're almost down to being undetectable. That's the level here of these dotted lines. You can see people who've had more booster shots have a less steep decline and still retain some protection. And people who had a breakthrough infection and had been vaccinated have the most protection. So that the most protected people now are going to be people who've had their booster shots and people who may have had at least 1 prior infection. This is kind of building up immunologic memory. So what are we doing with our vaccines? Well, the strategy of any vaccine plan is to educate your immune system so that it knows what to look for when you actually see the real virus. So the vaccines that we're using right now primarily are mRNA vaccines, and they cause your body's cells to, at the site of injection, to express that spike protein that I've been showing you that looks very much like the spike protein the virus would make if you became exposed or infected. Your immune system sees this, learns what it looks like, and when it does see the spike protein from a real infection, it very quickly makes a response and decreases the likelihood of the infection taking, and more importantly, decreases the rate at which the viral levels can increase in your body and helps you recover without getting as significantly ill. There are 2 branches of the immune system. One is the antibody response, and I've been talking mainly about this neutralizing antibody response. This is what we make mainly to the spike proteins, and this is what the vaccines are made of. This part of the immune response is more important for preventing infection. As I showed you, as we get farther and farther away from the original variants, the neutralizing antibody response gets lower and lower. So we get less good at preventing infection. We have more of these breakthrough infections that we've been talking about, even with prior experience with vaccination. But the important message here is that in addition to humoral immunity, we have immunity from killer cells, cellular immunity, that is immunity to the entire virus, including the spike, and that is much broader. So there's much more cross-reactivity with immunity made from one of the vaccines or from prior infection with these new variants. And this form of your immune response, this part of the immune response, is what clears out infected cells and keeps you from becoming severely ill, getting into the hospital and dying. And that's why, although we're having a large number of cases, we're having fewer people in the hospital and dying than in the early part of the epidemic when we had fewer cases, but more people in the hospital. Now, in terms of vaccines that are out there, the ones that are primarily being used in the US are these mRNA vaccines. They and these viral vector vaccines, the Johnson & Johnson vaccine, which we're not using very much anymore, are capable of making both humoral and cellular immunity. And that's why we think they're very important and very useful here. And this is one of the problems with where China is right now. They have not been using these mRNA vaccines. They've been using vaccines made from killed virus. And these vaccines are better at making antibodies than killer T cells and don't make immune responses that last for very long. So with their strict lockdown policy, they're in a situation in which they have a large number of people who've either been under-vaccinated with a vaccine that's not very good, or have not been vaccinated at all because they haven't felt the need to because they haven't had cases. And now as these new variants are more and more transmissible and people are less and less willing to stay locked up, they have a large reservoir of people who could get severely ill if they suddenly reverse the zero COVID policy. So it's going to be a bit of a challenge in dealing with this, certainly in China over the next several months. Now, where are we going to go here? A lot of it depends on two things. One is how much our immunity in the population stays up. This will depend on how well we can keep people vaccinated. Staying up to date with immunity is the best way to stay out of the hospital, particularly if you're older or have underlying conditions. And how many people already have immunity from prior infection. We have a lot of people who've had a bout of COVID, and that just adds to the level of immunity in the population and decreases the ability of the virus to run through the population. The other factor is going to be how much viral evolution we have. As I showed you, viral evolution has continued to accelerate, and I think that it's clear that we're going to have an increasing run of new strains, and we can't just rely on immunity that we developed to old strains to protect us from new strains. We have to continue to pound on this immune reservoir with active vaccination. So what can you do to protect yourself this fall? Stay up to date on your COVID vaccinations. Influenza is also going to be big this year. One of the reasons for that is we've had 2 very low influenza years with people masked and staying home with COVID. And just as in Australia, which has an opposite season from us, they had a very bad influenza season in their winter, which was our summer. We're starting off with a much more rapid uptake in the influenza season this year than in the past 10 years. And it's going to be very important for people to also get influenza vaccination to stay protected from influenza. It's very worth keeping some home test kits around the house. They actually work pretty well, including against the new strains. One thing to keep in mind is that sometimes when the symptoms first appear, the test can be negative. So if you test negative one day, it's worth testing again the next day or the following day just to verify that you're continue to be negative, and you should stay away from people if you have symptoms until you have this sorted out. As we begin to see the virus spreading around more over the Christmas holidays, it's not a bad idea if you're in a place where there are going to be a bunch of other people to wear a mask. I still wear a mask in the grocery store. I'll still wear a mask when I go to the movies, particularly with this increase in cases we've seen over the last few months. I'm less rigorous around the house or around friends, but I think we're in a situation now in which particularly people who are vulnerable should consider masking in public places where there are lots of people, particularly indoors. And if you do then become ill, it's really very worthwhile talking to your physician about whether you should take one of the increasing numbers of antiviral therapeutics, especially Paxlovid, to decrease your likelihood of becoming severely ill and ending up in the hospital. So with that, let me stop, and I'd be glad to entertain any questions or comments anybody has. I thank you very much for your attention.
Thank you very much for your great talk. I have a whole lot of questions that I will defer until I hear if other folks have some questions. Nobody put anything in the chat, but I didn't either because I was too busy listening to type. So let's see, I can't see faces right now to see. Let me just look at the gallery. You can also unmute yourself if you have a question. Would someone like to ask a question, Dr. Schooley?
Wide open if anybody has any questions to ask or
okay.
comments.
Okay. Well, I'll get started. I have a couple of comments too. One of the lessons learned, something that really I think should be added, is that I thought that the government and all the different agencies, public health agencies, were extremely slow at getting out public service announcements. about the virus or any kind of dissemination of truth to combat all the misinformation. And the misinformation we know is just was devastating for people for COVID. But I'm seeing public service announcements now telling people to get the vaccine 3 years later, and there was nothing for months to years. Do you know anything about that?
Well, what seems to be happening, I think, is a result of Rochelle Walensky taking over the CDC. In the prior administration, the CDC was very carefully monitored and controlled by the White House. And everything that went out had to go up the chain and come back before these public health announcements were made. And under the new reorganization, the public health decision-making and communication is being reallocated to where the professionals are, which is Atlanta, not Washington. And I think that's actually helped in terms of accuracy and timeliness with respect to public health communications. I understand politicians want to reassure the public, but it's, I think, better to have people working in the field, the public health authorities and the scientists talking to the public than having politicians who A, don't understand the science, and B, sometimes misrepresent it for other reasons.
Okay, I'm going to ask a question here, and then I have a follow-up to that. Elizabeth S., how long does the latest vaccine version give protection? Should we repeat it after 6 months?
We're learning as we go with this. We think that people who have either had a bout of COVID or have been vaccinated have a very high level of protection from reinfection for at least 3 months, that then begins to wane for the next 3 months. Now, having said that, once you've been vaccinated or have had a bout of infection, your likelihood of having a severe reinfection is much lower. So you may get infected, but you'll get infected with a much less severe illness than if you hadn't been vaccinated. At this point in time, the current recommendation is if you have not been vaccinated in the last 5 or 6 months, and have not been infected in the last 3 months, to get this hybrid booster. I think we'll see in the course of the winter what happens with how durable these vaccines are, and whether we need another vaccination toward the end of the respiratory virus season. I would not be surprised at all to see us needing another round of vaccinations in March or April, particularly those of us who are over 60.
I have a follow-up to that, something that really bothered me. I saw on the national news last night, and I can't remember which program, Dr. Ashish Jha, who we followed for many years and respected what he had to say, sounded very political to me, or wishy-washy or something, because last night he said that being asked about when people should get vaccinated and boosted, that it would be something that everyone should do once a year, knowing that the immunity wanes. It's really good for 3 months, and as you said, it wanes, but it's still good for 6 months. I would not be comfortable going for a whole year based on everything that I've read before getting another one. And it's unfortunate because it's very convenient to tell people to get one once a year, like your flu vaccine, or get them at the same time. But it doesn't follow the science.
No, I would agree with you. I think that a more accurate answer would have been that we know immunity is waning. We're going to have to see whether the new wave of COVID BQ1 increases immunity in the population with asymptomatic infections, and low-key infections will be following the level of immunity of the population, developing new vaccines. And we don't yet know when a new vaccination is going to be required, but to give a timeline, it will be these will be yearly. I think right now we don't have the data to be that certain. It would be fine to say eventually we may end up in a situation with flu like once a year, but we're not there yet, and we'll have to follow what happens over the winter, which is the way I would have answered it.
Yeah. Just going along with that, I was interested in your slide showing the different peaks of numbers of cases in the US depending on the variants. And, as like, especially Omicron was really dramatic. And I was looking at the seasonality, and I know that many different viruses have a seasonality, and it's not always in the winter when people are cooped up together. Sometimes they're higher in the summer or fall or something. It doesn't have to be so. And I didn't see a seasonality because we have 3 years of data that you just showed. I didn't see it peaking in the winter or any other time. It depended on the introduction of a new variant. Do you have any sense of if it is going to be, or we're just going to wait and see for this winter what happens?
I think we will have another little bit of a surge this winter. And I think that this virus is new enough in the human population. We're not at equilibrium yet. And so because of that, when a new variant comes along, whether it's winter or summer, it gets going and we have a peak. We're more susceptible in winter for a couple of reasons. First of all, as you've already said, we're more likely to be indoors together with the windows battened down to conserve heat. But we also heat the air, which lowers the humidity. These viruses, as Kim Prather and others have shown, are found in very small aerosols that are generated deep in our lungs. These aerosols hit the air as we exhale and immediately begin to dry out because of the lower humidity outside than deep in our lungs, which is basically 100% humidity. In lower humidity situations, as they dry out, these particles stay lighter and they stay up in the air for a longer period of time. So aerosols are more transmissible because they are more persistent in the wintertime. Some of the summer viruses are ones that are actually spread in water, and we swim and do things like that. But these aerosolized viruses are ones that are highly affected by proximity to each other and by the size of aerosol particles.
Okay, very good. There's another question in the chat that is kind of along what we talked about, but I think they're asking how soon am I going to be protected after I get a vaccine? The question is, once you get the most recent vaccine, how long does it take to become most effective?
Well, the immune response that you get after you've already seen something once is called a memory response, an anamnestic response. And one of the characteristics of a memory response is that in addition to being a more vigorous response at a higher level, it occurs earlier. It's accelerated. And so that you can start seeing new levels of antibody occurring within 3 or 4 days of getting a booster shot because of your memory responses. It may take 10 days or 2 weeks for the same kind of kinetics to occur when you've seen something for the first time, your first shot. Your maximal level of immunity isn't really reached for several weeks. And in addition to that, under the surface, your memory responses are refining themselves so that if you see the antigen again, with a more mature memory response, you get an even more vigorous response. And that maximization occurs over a 2 to 3 month period. That's one of the reasons we don't recommend people get vaccinated right after they've had COVID. It's not because it's not safe, it's just because by letting the memory response have a couple of months to mature, when you do see the antigen again, your immune system really takes off.
Okay, I have a couple more questions, but I have one more in the chat here. Nancy Dimsdale says, a friend had 2 Moderna vaccinations plus 2 Moderna boosters. Then he received Evusheld, 2 injections, one right after the other. Maybe you can tell me what that is. I don't know what it is. Does Evusheld protect him, or should he get the 3rd Moderna booster ASAP?
So Evusheld is an antibody, a monoclonal antibody that is given to increase the level of neutralizing antibodies in the bloodstream. And we use it mainly in people who are not able to respond to vaccines because of underlying immune defects or people at significant risk for the disease. Unfortunately, because BQ1 and BQ1.1 are new variants, Evusheld doesn't cover them well, and one shouldn't rely on Evusheld to protect against BQ1 and 1.1. Evusheld is still being given to people who are at significant risk for COVID, but the level of protection is much lower than in the past, and so many people aren't really advocating giving it as we were, for example, a year ago. As to whether or not to get another vaccine, what I would encourage the person to do would be to sit down with their physician, go over the timetable, whether or not they've had COVID and when, and then make a decision based on all the data in front of them. I kind of hesitate to give advice about a specific patient without knowing the whole story.
That's good. Yeah, thank you. I just to follow up on that one, it was a question I was going to ask because I wasn't sure about the name Evusheld, but I know that there are many monoclonal therapies that have been developed. I don't know how many there are, but I know there's more than one, and that I had heard that they're becoming less effective with the new variants. And I was wondering, that's for people of concern to people who are immunocompromised and can't benefit from these monoclonals. Is Paxlovid then the only thing that they'd be able to get if the monoclonals are not effective?
The monoclonals are becoming less effective because they are made using the original spike protein from the virus we talked about that first kind of made its way to the US. So just as our immune system is behind the curve, the monoclonals are behind the curve. And that will continue to be the case. And even more the case as evolution accelerates. Paxlovid is still active against all variants that we have. And that's something that people in high-risk groups in particular, and I'm actually, I don't think you need to be someone with who's had an organ transplant and has lymphoma and is 110 years old to be a high-risk person. I think people certainly over the age of 55 should strongly consider getting Paxlovid if they get infected. The only two difficulties with Paxlovid are that there are some drugs that have to be that are difficult to give with Paxlovid just because the metabolic effects of Paxlovid cause those drugs to either have a longer half-life or a shorter half-life. Physicians and pharmacists have tables they can use to look at your drug list and know whether or not that affects you. And for many of these, all you really have to do is modify the dose of the other drug for the 5 days you're taking Paxlovid. The only side effect people are aware of that I know of is that you may have a little bit of a metallic taste in your mouth when you take Paxlovid. I took a course of Paxlovid in the summer. I had some visitors from Europe who brought me COVID as their gift. They were staying in my house. And so I had a really sore throat and felt pretty lousy and took a course of Paxlovid and noticed the metallic taste. It wasn't a major problem. It allowed me to get rid of some of the cheaper wine that I had stored, but it is something that some people really find annoying. For people who can't take Paxlovid and who are at high risk, we can also use remdesivir. Remdesivir has to be given intravenously, but a 3-day course of remdesivir, which can be done as an outpatient through UCSD Health, can also decrease the likelihood of being admitted to the hospital if you get infected and are at high risk.
I have a question. Judy, may I go ahead?
Of course.
So I was interested in what you thought now with the evidence we have about the origin of the virus, whether there's any truth to the story that keeps persisting that it might have escaped from a lab, been manufactured in some way, as opposed to coming from maybe wildlife in a market.
I think the best evidence is that it's wildlife in the market because there were 2 strains that appeared, not just one. And when you go back and kind of trace the dendritic tree backwards, and that suggests to me more of a spillover from a virus that had been being passed around the animals and then got out in the community in parallel over a couple-month period. So I think it's very difficult to make a case that this was a laboratory accident. Now, having said that, these viruses are ones that have to be handled very carefully in the laboratory because they, if you make an aerosol with a pipe, by pipetting them, for example, in a place where there isn't good airflow, the virus is easily inhalable. The only couple of cases of the original SARS we've had, the original SARS by the one that, by that I mean the one from 2003,
Right.
have been cases that were acquired from laboratory accidents. So
Oh,
it's
wow.
not by any means out of the ordinary to think that this virus could have escaped from the laboratory. But I think the genetics supports more the wildlife evolution to begin with. Unfortunately, I'm not sure we'll ever know. We don't have the records from full records from the laboratory, and the wet market was kind of shut down and torched before people really were able to investigate it. So I don't know that we'll ever really know the true answer to this.
Thank you.
I have two more questions in the chat. By the way, this is the most questions we've had from for speakers for quite a while, so I'm delighted. One is there a maximum number of shots? It says allowed, but that would either be allowed or that are recommended. I guess is there any issue with continuing to get vaccinated?
No, there's no real issue about that. Right now, if you've had your original 2 RNA vaccinations, for example, then the booster shot, and now the hybrid shot, you'd be up to date with 4 vaccinations. So there's no, and that's kind of what people will be told if they go and ask for a 5th vaccination. You're up to date. Someone who's had the original 2 shots and then didn't get a booster, but then got the hybrid, say in October, would also be up to date. That person will be up to date with 3 shots. So a lot of it depends on what's happened in between your original vaccination series and your most recent booster as to what up to date would be.
Okay, so here's one that's, I think it was probably from Vicky, hard to write down, but I think I can understand it. Does the fact that there are an increasing number of variants mean that each of those is evolving in its own way and therefore multiplying the issue of evolution of the virus to result in an increasing number of variants?
Yeah, the virus is kind of, as you saw, is looking more and more like a broken plate instead of kind of going down one road. It's all Delta now, it's all Alpha now. And we have one offshoot from the BA4, BA5 line that is turning out to BQ1 and BQ1.1. Then an earlier Omicron offshoot, BA2, is giving rise to the next big thing, which is going to be the XNN strain, that will likely come after BQ1 and 1.1. Now, these are genetically different when you look at the sequences, but what these viruses are all doing is the same thing. It's convergent evolution. They're learning to invade the immune responses we have by changing the shape of the spike protein so our prior previously developed antibodies bind less well, and so that the spike protein can bind more tightly to target molecules on the surface of cells that get infected. Normally these viruses come and they attach and they fall off, they attach and they fall off. But one of the evolutionary adaptations they make is to make this first attachment be stickier so they don't fall off as quickly and then can get in. And so part of this convergent evolution is to find different ways to be sticky. Even though the genetics may be going in different directions, the goal is the same. Yeah. The other part of this that we're not seeing as much is these viruses are very sensitive to our innate immune systems, and innate immune systems include interferon and other molecules that we make whenever we see things like double-stranded RNA. You don't have to know what the virus is, you just know there shouldn't be double-stranded RNA there. You make interferon immediately. These viruses really don't like interferon, but they also have make products with the genetics, the genes they bring with them that turn off our immune responses. That part of the viruses is also evolving and getting more effective at turning off our immune responses, which allows the viruses to grow up more rapidly when you become infected. That allows you to be more infectious before you become symptomatic to spread the virus more quickly to other people. So the virus is having these two evolutionary trains occurring at the same time. Although the genetic sequences are diverging, the goals of the virus are converging with being more transmissible and less responsive to immunity.
Just to follow up on that, it sounded kind of like what Vicky was asking was, are there going to be all these different variants that we're going to have to be immunized against? But my understanding of what's happened up till now is that one of them usually takes over, and then we don't, the other ones, I'm not sure what happens to the other ones. I guess they just disappear from the population or at a real low level or something.
Yeah, they just can't be, they're not competitive with what's circulating, so we see them just gradually die out. She's right in the sense that we're having, in the past, we'd have an alpha wave, then a delta wave, and you'd see almost nothing but that in a given population. We're now having waves, but with several different viruses present at one time.
Mhm.
There is a lot of work going on now trying to develop a so-called universal vaccine that will make immune responses to parts of the virus that haven't been varying. You can analyze what parts of the spike protein are vulnerable to antibodies. And you can also analyze what parts of the spike protein have tended to evolve less rapidly over this last 3 years. And try to find ways to make antibodies to the parts of that spike protein that hit both buckets, so you have a vaccine that induces immunity to a broader array of strains. A lot of work is going on with that. Walter Reed, U.S. Army, is working on that, among others. We don't have a vaccine like that yet, but that's one of the things people are working on. The other thing that can be done with mRNA vaccines is you can string together several different spike proteins on the same RNA strand, and you can end up giving people a vaccine that expresses more than two different spike proteins. And then finally, as I said earlier, in addition to trying to induce immune responses to the spike proteins, we're inducing cellular immune responses, which are responses to very short peptides of 8 or 9 amino acid segments. And each vaccine makes us make killer T cells to recognize multiple different of these short segments that are present in all of the variants. And this is what helps protect us from severe illness, even if it doesn't protect us from infection, because it's stimulating that killer T cell response as opposed to the neutralizing antibody response, which is on the surface of the nose. But to answer the question more succinctly, yes, it's getting more complicated in terms of what's out there.
That makes me realize that you did not even touch on something that I mentioned as one of your job titles with the phage immunotherapy. We might have to have you come back and give a talk about that some other time, I guess.
I'll be happy to do that. I had enough rambling. I was afraid if I rambled about both, people would be in coma by the time 1 o'clock rolled around. So
no, this was fabulous. But we did have Stephanie Strathy actually at Sounding Board 2 different times. The first one was about her work with the prostitutes in Tijuana, which was fascinating with HIV. And then the second one was about her husband, Tom Patterson, and his multiple drug resistant bacteria that he was saved with the phage therapy, which was just a gripper of a talk. And I recommend people watch that on her TED talk. Is remarkable also. So are there any other last questions for Dr. Schooley? I don't see anything in the chat. Well, I want to thank you very much for just a fascinating talk today. Oh, I do have one quick question. Just one quick one. based on all the things that we just talked about in terms of all our boosters and whether we'd been infected or not, and everything that we've talked about, would you, are you eating inside in restaurants?
Yeah, I am now. I mean, I'm not yet at the point yet that I'm not willing to eat in restaurants. If I've been well immunized. I managed to have my European visitors last summer, so I'm pretty well tanked up. I'm a bit older, but I'm not. But I don't have any other underlying illnesses. It's one of the risks I'm willing to take. Now, if we see, if I were someone who, for example, had a renal transplant or on immunosuppressive drugs or had COPD, I would rethink that, seeing where the wastewater is going and things happening at a more rapid clip here in December of 2022, and wait till things quiet down again to do that. I didn't eat in restaurants for a long time for that very reason, but I've been willing to do that certainly this last fall.
Because as I mentioned at the beginning, Sounding Board usually meets at the faculty club for a lunch for a speaker, and we haven't done that. And we're agonizing because most of the membership is in the age risk category. So,
I mean, I think it would have been okay to do it today. I think I would probably wait about scheduling January or February indoors until you see what happens in December.
okay.
It goes in waves, and one thing that's nice about the faculty club, it actually is pretty airy, and you can use that the lounge and have the doors open and get quite a bit of ventilation. So it's a much better place than a more trendy restaurant in Pacific Beach with the Jell-O shots.
Right.
Okay, well, thank you so much. We really appreciate your time today. Thank you very much.
One
Thank
last,
you very much indeed. Thank you.
thank you. It's been great to be with you. And there's one last question from Vicki Lindblad about the sewage report.
Oh, I see. I see.
Yeah, you can see that it's on the website. If you just put into your Google search engine Point Loma wastewater, SEARCH, that's the name of it's the search alliance that finds it. If you put in Point Loma wastewater search, it'll take you to the site.
Very good.
Then you can bookmark it. Okay.
Very good.
Thank you.
Okay.
Thanks very much.
Goodbye, everybody. Thanks for
Bye.
paying
Bye.
attention and for all the great questions.
Thank you.